Once again, thank you very much for the invitation, and I'm going to, in the next half an hour, I'm going to take you to a trip in a praxis-orientated German view on acute lymphoblastic leukemia. During this talk, I'm going to talk about following matters. I'm going to spend a few minutes about diagnostic, a little more minutes about treatment strategies and current recommendations. We are going to talk about the role of minimal residual disease in the treatment of ALL, about the role of allogeneic transplantation, about modalities of treatment of elderly patients, relapse strategies, and how we can incorporate everything that I mentioned in a common and in a unique concept. So first of all, let's start with diagnostics. According to the literature, there are very many potential adverse factors prognostic factors in ALL, and it is absolutely not possible to integrate all those factors in a treatment schedule which is lasting for more than 2 years. Anyhow, a German ALL study group has the following approach. In case of B precursor ALL, the risk factor is a hyperleukocytosis. The following cytogenetic malformations like translocation 922 or translocation 411. In case of T-ALL, it is early T-ALL or mature T-ALL. And we have also, during the course, the persistence or reappearance of MRD. When we integrate those factors, we have three groups of patients. We have a group of standard risk patients, we have a group of high-risk patients, and we have a group of very high-risk patients. And those very high-risk patients are actually the ones who are Philadelphia positive. So in case of high-risk or very high-risk patients, we have an established strategy. Those patients need an allogeneic stem cell transplantation during the first complete remission. And in case of standard risk, there is normally no necessity for allogeneic transplantation, but in cases of molecular failure or molecular relapse, those patients have to be transplanted. So what does the protocol look like? The protocol, the current recommendations of the German ALL study group are actually a combination, a repeating combination of different cocktails of chemotherapy. And the whole treatment protocol lasts for 2.5 years. The first year is quite loaded with chemotherapy, and it looks like this in this concept. So every patient receives a pre-phase therapy, then an induction in 2 phases, and consolidation 1. And after consolidation 1, we decide if the patient continues within the chemotherapy, or if he is in case of high risk or very high risk, if he has or she has to turn to allogeneic stem cell transplantation. This backbone is actually taken from the pediatric protocols, from the BFM-based pediatric regimen, and has some other aspects like PEG-asparaginase and high-dose MTX, which is a little bit different to the BFM. So in Germany, till this year, we had till a few years ago, we had a study called 07-2003, and the results of these studies were published and were presented on very many congresses. So anyhow, in this study, in the last study, 07-2003, which was running till 2011-2012, there were evaluable 1,800 patients, and the data are quite good. If you see, we're talking about ALL, we have a common group of the patient, and we have overall survival at 3 years of above 60%. When we defer it to age groups, we see that the overall survival of the young patients, of the young adults, meaning 15 to 25 years, is excellent, but the prognosis of the persons in best years is actually something that we can optimize. We said at the beginning that allogeneic transplantation is indicated in high-risk patients or in the patients who get MRD positive during the course of the therapy. the results of the stem cell, of the patients who had an indication for transplantation, the prognosis of them is better, of course, in transplant setting than in non-transplant setting. In terms of donor, there is no significant difference. The guidelines for treatment of ALL patients in Germany have two different methods regarding the comparing to the American guidelines, for example, and it is intensification of PEG asparaginase. In the last protocol, the total dose of PEG asparaginase was 4,000 units per square meter, and in the protocol 0703, it is a total dose of 14,000 units per square meter. This intensification of PEG asparaginase led also to increased toxicities, and we saw toxicities regarding liver failure, and we saw also increased infection rates. After a few years, it was possible to define the patients who are at risk for developing the toxicity complications, and those are the adipose patients, the patients with steatosis hepatis, and the patients of above 45 years of age. So in the meantime, our learning curve regarding the treatment of PEG asparaginase increased, and we have a sort of a guideline how you manage the toxicity of PEG asparaginase. The intensification of PEG asparaginase treatment led also to improvement of the prognosis of the patient. So on the left side, you see the curve of the patients treated with intensified protocol, and down it's the curve of overall survival of the patients treated with the old protocol, and you see it is a statistically significant difference. Another backbone is the dosage of rituximab. Rituximab is not licensed for the use in ALL, but you're going to see in the next slides the data from American and from the German groups, and after positive data, in one of the amendments of the protocol, rituximab was induced. The cutoff for rituximab is positivity of CD20 at least level of 20%. The data from MD Anderson showed that addition of rituximab to Hyper-C, but it is a standard protocol in the States, improved the prognosis of the patients, improved the rate of complete remissions. In Germany, it was not proven that rituximab can improve the incidence of complete remission, but induction of rituximab could improve the influence, had a positive influence on the minimal residual disease. And that's why the protocol has 8 dosages of rituximab. I've mentioned the term minimal residual disease. Minimal residual disease is measured in Germany in centralized setting. It is the laboratory in Kiel under the leadership of Professor Brüggemann. The way to measure MRD is PCR technology. It's actually the analysis of clonal rearrangements of immunoglobulins, and it can offer us to detect the disease in a very low level, meaning one leukemic cell at about 10,000 cells. We know that according to the data from 0703, that the patients who do not get allogeneic stem cell transplantation and who are in a molecular remission, they have quite a good prognosis, but molecular failure is a sign for a quite desperate prognosis, and it is during the time we learned that the MRD positivity is a new risk factor, and the MRD positivity is actually the new very high risk. The patients who are MRD positive are at the very high risk of relapse. So we are standing in front of a dilemma. If we have a molecular complete remission, should we intensify the treatment? Should we maybe avoid allogeneic transplantation also in high-risk setting? On the other hand, if we have a molecular failure, should we perform the stem cell transplantation immediately, or should we try to deepen the response before the transplantation and to transplant the patient with very low tumor burden? The retrospective data show that the remission duration after stem cell transplantation is also correlating with the MRD positivity or negativity. So the patients who were transplanted at the point of transplantation who were on the molecular negative, molecular complete remission, they had quite an excellent prognosis. The question is how we can achieve a molecular response before the transplantation. And one of the settings was to give those patients during the course of after the course of the chemotherapy, to give them blinatumomab in case of minimal residual disease. Here are the data from Mr. Top. He published them at JCO 2011, and he could prove that relapse-free survival without stem cell transplantation is possible. And in the BLAST study, which we in University Leipzig also took part in, it was a European study for treatment of patients who were positive on molecular level, but in a complete hematological remission. We gave blinatumomab, and we showed that we could we could achieve a complete molecular remission. After achieving the complete molecular remission, those patients had to be transplanted. I'm going to come to this point. Here are the adverse events of the therapy, and the adverse events were mostly pyrexia, headache, and neurological adverse events. Anyhow, they were in the BLAST study. They were quite manageable, and without at least in our unit, without having caused the interruption of the therapy. Only in 2 cases there were side effects of grade 5. One patient died of subdural bleeding, and one patient died of pneumonitis. This concept is, so to say, the base of the new concept which started in Germany in 6 or 8 centers. We are one of them. And this concept is called MOLACT. MOLACT is a sub-study of the new GMALL study for treatment of B-ALLs, where you can give blinatumomab in case of MRD positivity on the level 10 above -4. We are here I'm going to tell you a few words also about stem cell transplantation strategy. The patients who are about to be transplanted are normally the patients who are having high risk, who are having very high risk, or who are getting positive, MRD positive during the therapy. And there is first question, when do I transplant the patient with the ALL? And there is a consensus that we do not, or we should not, apart that there is a really medical emergency, that the patient cannot tolerate any chemotherapy anymore, but the time point of transplantation should be the consolidation 1 in order to remove the tumor burden as much as possible. In terms of donor, the donors who are accepted should be siblings or non-siblings, HLA matched, and the conditioning regimen is defined according to the age of the patient. For example, the younger patients should be transplanted with etoposide and 12-grade total body radiation, and the older patients should receive a reduced intensity conditioning regimen. This table that I'm showing you was issued in January 2017 after consultation of very many transplant centers. Among them also Professor Niederwieser took active part in the development of the strategy. In our center, we do perform a RIC allogeneic transplantation, and we presented the data at the German Hematology Oncology Symposium and at ASH 2014. about 28 patients which we transplanted with this setting. We used conditioning regimen with fludarabine and 2-grade TBI. As you can see, 8 patients are younger than 55, so according to the general recommendations, they shouldn't be transplanted with this regimen. On the other hand, those are heavily pretreated patients in 2nd or 3rd complete remission, and those heavily pretreated patients were frail for conventional 12-grade TBI or etoposide cyclophosphamide regimen. In this quite heavy pretreated and very ill population, we had 2-year overall survival of 49%, and interestingly, the patients with Philadelphia chromosome positive ALL, most of them are still alive now and without the signs of the disease. We are coming to the question of elderly patients, and elderly patients are a very heterogeneous group, and if you remember one of the first dias, I showed you the curve of the patients above the age of 55. There is also data showing the curves for the patients, for the frail patients, with quite very bad prognosis. Anyhow, an elderly patient, somebody who is 55 or 56, is not, his fitness stadium differs from person to person. So it is necessary to define, is this patient capable of coping with the chemotherapy? Is this patient capable of eventual allogeneic stem cell transplantation? So the German ALL study developed a concept for frail patients who you treat with palliative mild chemotherapy regimens, and also for fit patients in whom you can perform chemotherapy regimens, or even try in the future to go to the targeted therapies. So the current treatment standard looks like this. It is also, as a backbone was BFM concept used, but the number of chemotherapies are quite reduced and adapted to the patients who are above 55 years. Now we are standing in front of the question, can we reduce the load of chemotherapy and give something else? And I'm going to dedicate a few minutes to the new antibodies, but I will take you to a small excursion to the ASH Congress 2014 and to ASH 2016, where the doctors from MD Anderson in Texas presented the concept of treating elderly patients with inotuzumab ozogamicin. Inotuzumab ozogamicin is a conjugated antibody, anti-CD22, conjugated with calicheamicin. Calicheamicin is a toxin, and after ingesting this toxin, the tumor cells dies. They reduced the hyper-CVAD, and they reduced it quite rapidly. If you can see, dexamethasone was reduced to half, methotrexate to 75%, and the anthracyclines were removed from hyper-CVAD. So it was not hyper-CVAD anymore, but hyper-CVD. And instead of adriamycin, they put inotuzumab ozogamicin in a age-adapted dosage. So they treated 27 patients, 26 were evaluable in year 2014. They added the follow-up 2016. Anyhow, the complete remission rate was fascinating good, with 96%. MRD response was 77%. 2 patients relapsed and 4 patients died. Interestingly, 1 patient died of a shot wound, so I think in Texas it is usual to take guns, and but no comment about it. Anyhow, the patients had quite a lot of infections and hematological adverse events. So talking about relapse, the prognosis of the patient after the first relapse is bad. About 22% of the patients are alive after 5 years, and in the case of second salvage, the prognosis is even worse. The patient who gets to remission after relapse is a candidate for allogeneic stem cell transplantation. So we are standing in front of the question, the patients who relapse after having had a therapy for 2 or 2.5 years, what is left? What can we give them? Because a heavily pretreated patient is hardly going to cope with the new blocks and new cocktails of chemotherapy. So we have a question, do we have molecular targets? Yes, we do, but we do not have such molecular targets that are present in 80% or 90% of the patients. And we skip now to immunology. We know that about 80%, 90% of for example, B ALL cells are CD19 positive, 90% are CD22 positive. So one of the best targets is CD19 positivity, and one strategy for it would be blinatumomab. Blinatumomab is a combined antibody. Actually, it is a linkage between fragments of antibodies. If you can see here, it is FAB of CD3 and FAB of CD19, making a small molecule, and this small molecule is binding the T cell to the tumor cell. On this way, one skips the HLA restriction, and this T cell can destroy the tumor cell. I'm going to show it to you now what it looks like really in vivo. Please concentrate on the right screen. Now you see here the tumor cell. The small cell jumping around her is the T cell. She's dead. Look at this one now. She died as well. And so we can put the movie for the next 2 minutes when we are going to skip it now. In case of relapsed refractory ALL, there were many studies till now, and blinatumomab got licensed from the European Medical Agency. I will make a short walk around those studies. Mr. Top and Mrs. Gugboget published in Lancet Oncology 2014 the 211 study with 36 patients who showed after 2 blocks of blinatumomab, the patient had overall survival of 6.1 months, showing that blinatumomab is a bridging to allogeneic stem cell transplantation. Is an effective therapy, but is a bridging. And in this setting, they treated patients with a lot of tumor load. So there are other the adverse events that you saw in the molecular relapse setting are more intensified. A lot of patients had febrile neutropenia. Neurologic events were present at least 50% of patients, and quite a lot of them had a headache as well. On the basis of this study, in Europe we started with Tower study, and Tower concept was blinatumomab versus standard care of therapy without possibility to switch, meaning we had a therapy which we thought is better, and we had no opportunity to switch the patients. And in the interim analysis, the curve was like this. So it was a clear advantage of blinatumomab patients, and European Medical Agency licensed blinatumomab for relapsed or refractory disease. It is a very good decision. But on the academic point of view, we have a problem now to analyze the effect of chemotherapy, because the patients who were in the chemotherapy, quite a lot of them switched after having license for blinatumomab into blinatumomab arm. A lot of patients were transplanted, so the statistic of the study is very problematic. Interestingly, the both curves meet here. So we know for sure that blinatumomab is an effective option, but it's also only a bridging to allogeneic stem cell transplantation. I don't want to neglect another antibody. It is inotuzumab ozogamicin. Inotuzumab was also, these are the data which were presented in EHA 2016. Inotuzumab was given in an INNOVATE study in America, and they had similar concept of like tower. As you can see, the curve split here as well, and inotuzumab is also something that we understand as a good bridging to the stem cell transplantation. The firm, it is Pfizer, they applied for allowance of the drug. When we are talking about relapse strategies, I think it's necessary to dedicate only a few words to the CAR T cells. CAR T cells are actually chimeric antigen receptor T cells which look like this. You take, with the genetic engineering, with the insertion, with the gene transduction, you can generate a T cell with the T receptor, with the recognizing part of the T receptor actually belonging to the B cell. It's complicated what I'm saying, but on this way you skip the HLA restriction, you skip all the mechanisms that limit the T cell for its work, and you perform a army of professional killers, so to say. They are T cytotoxic, they proliferate, and they survive. And what does it look like in a clinical setting? You perform a T cell collection in a GMP lab, in a pheresis lab. You perform a T cell transfection, and after about 13, 14 days, you have a CAR T cell infusion. The patient has, before the infusion, reinfusion of the CAR T cells, the patient gets lymphodepleting conditioning, usually with fludarabine and cyclophosphamide. And after giving the CAR T cells, they start working, and you follow it by bone marrow investigations, by imaging investigations, and by the investigations of the blood. Side effects of the CAR therapies are a subject of very many publications. I'm going to just go through them. It's a cytokine release syndrome, it's neurological events. Those patients are quite a long time B-cell aplastic, so a substitution of immunoglobulins is something that is anyhow necessary. They can get quite a lot of infections. Interestingly, in the data published by Shannon Mott, the patients who were previously allogeneically transplanted, they did not get any GVH. And here you can see the survival curves from the group of Mott and Carl June in Philadelphia. So I've been talking about the diagnostic. I've been talking about standard treatment. I was talking about relapsed patients, about strategies, how to define and how to manage minimal residual disease or relapse. So all of those things are being, the German ALL group tried to put all those things in one common concept, and this common concept is the new trial, 0813. We were waiting for 2 or 3 years to start, and we started with it in Germany starting from this year, and Leipzig is also one of the centers already enrolled 2 patients there. The aims of the new studies are to avoid relapse, to reduce tumor load, to test anti-leukemic activity with endpoint minimal residual disease, and to find the optimal setting for single drug strategies like blinatumomab, inotuzumab, CAR T cells, dasatinib in case of Philadelphia positive ALL, also nelarabine in case of T cell ALL. So the concept is definitely not simple, and there are very many stratifications and very many curves and very many crossroads in order to put the patient to the end of the therapy. This is the overview of the 2nd and 3rd year of the therapy. And I think ALL is an enormously evolving field, extremely interesting part of hematology. And I think we are going to see in the future the definition of new molecular targets. I haven't dedicated a lot of time to so to say, sub-entities like Philadelphia, like ALL, and I think the role of next-generation sequencing of the new diagnostic modalities is going to increase in the ALL. We are going to see the integration of cellular therapies in current concepts, combinations maybe of checkpoint inhibitors with bivalent antibodies or with CAR T cells or second generation, or production of CAR T cells for other targets, or further development of cellular therapies. And I would like to thank you for your attention with one photo from Leipzig, and I'm looking forward to questions.